So good evening. I am Christy Castillo-Catoni. I am one of the physicians with Northern Virginia Family Practice. I hope you all have enjoyed the summer. I know we're all kind of coming back to our routines. Kids are back to school. So welcome back to our Town Hall series. Tonight we are joined by a very special guest, Dr. Ira Marathe. Dr. Marathe is board certified internal medicine and also board certified in obesity medicine. She is a primary care physician with Lifetime Internal Medicine in Herndon, Virginia. And she is here to have a discussion with us about healthy weight management. And we very much would like for this discussion to be as interactive as possible with Zoom. Please do use the Q&A section. We will be looking at that. We will try to address as many of your questions as possible. And we're also going to have a few poll questions so we get a better idea of where our audience is at, where we may want to focus a little more on. So please do participate. And without further ado, we're going to go ahead and get started. Again, Dr. Marathe, thank you so much for joining us tonight. And let's have some fun talking about weight management.
Okay, thank you so much for having me. I'm super passionate about this issue, and I'm grateful for the opportunity to talk about it to another doctor who, you know, is really deeply committed to your patients, and we're all trying to help our patients, and I know our patients struggle with this, so I think this is a great opportunity for us to have a discussion and hopefully answer some questions for people that are working on this issue for themselves or perhaps a loved one. So let's talk about what's happening in terms of the prevalence of obesity in the United States. So this is a busy slide, but it's basically showing that the rate of obesity is steadily going up in the United States over the past 60, 70 years. So back in the 1960s, only about 10% of Americans were considered to be obese by having a body mass index over 30. Only 10% of Americans at that time. There is a big jump, you know, from I think 1980 to the year 2000. I think a lot changed in the way that our society functioned and what we did for work and leisure activities. So we went from 12% up to about almost 30%. And we've been hanging around the 30% for many years, but it's going to start going up again. And it's projected that by the year 2030, which is less than 10 years away, 50% of Americans will have a BMI over 30. This does not even count the additional Americans that have a BMI 27 to 30, overweight Americans. So the majority of Americans are going to be struggling with their weight. And why is this happening? And is it just in the United States? Well, it's not just in the United States. This is a global epidemic. So in the past 40 years, there's not a single country that has experienced a reduction in their prevalence of obesity. And this is despite, you know, our advancing understanding of nutrition, exercise, things like this. We know more and more, but somehow we're still dealing with this all over the world. So why has this happened? Lots of reasons. Food has changed, right? So food is become more calorie dense, more highly processed. We're eating more fast food. Portions are larger. I'm sure you can think of restaurants where you go and the portions, you know, what would probably serve a whole family of four now is put in front of you as for one person. Work has changed. So most of us are working desk jobs now. There's less manual labor that's happening. So if we want to get exercise or activity, we have to plan for that and make that a special thing. It's not part of our workday anymore. Leisure time has changed. So when I was a kid in the 70s, I was outside every evening until it got dark. That's the only time I had to come back in. My mom didn't know where I was. That's what everybody did, you know? And now, unfortunately, we're all, you know, kids, adults, everybody, we're on our screens all the time, right? And then the last thing that I think a lot of people don't think about is that we are taking more medications for other things that have weight gain as a side effect. So let me show you. These are some of the classes of medications that have some of the medications, not all the medications in each class that I've listed here, can be weight promoting or cause weight gain. So the older diabetes medications like sulfonylureas, glipizide, glyburide, and insulin all can cause weight gain. The newer diabetes medications are actually also weight loss medications, and we're going to talk about those down the road. Steroids like prednisone or Medrol, some antihistamines, such as Zyrtec that you might take for seasonal allergies, believe it or not, can be weight promoting. Certain blood pressure medications, especially beta blockers like propranolol, can be weight promoting. And then some seizure medications, some antidepressants, not all of them, but some of them can be weight promoting, mood stabilizers, antipsychotic medications. So, you know, big pharma, as it expands and the number of medications available for all conditions increases, a lot of them can have weight gain as a side effect. And so we think that, you know, the use of medications for other conditions accounts for about 10% of the obesity epidemic in this country. So just something to consider, and talk to your doctor about this if there's other medications that you could use instead if you're trying to lose weight. I'm sorry for the blurry slide. This is just showing what body mass index is. I referenced that already, and it is a measure that we can use, a metric, I should say, that we can use to determine if someone is dealing with obesity or overweight. And it is just a calculation of your weight in kilograms divided by your height in meters squared. So if that number is over 30, then you have obesity. If that number is between 25 and 30, you have overweight, and the normal weight is considered 18.5 to 25. It's not a perfect measure, but it's something that we can use to work with. You know, people sometimes will say, well, my BMI puts me in this category, but I'm big boned. I don't think I'm really overweight or obese. That's going to apply to some people, but I still think it's worthwhile to use it for most people. Another metric that can be used to determine if you have excess body fat is your waist circumference. So genetics kind of determine where we carry excess body fat if we gain weight. So, you know, there's the idea of some people are apples, we carry our weight in our abdomen, you know, and then some people are pears, they carry their weight in their bottoms or their legs or their thighs. And it makes a difference actually in terms of the risk of that excess body fat, because if you carry it centrally, which you don't have control over, it's just your genetics, then that's more dangerous in terms of cardiovascular and metabolic risk. It surrounds your organs, it's a visceral fat. So if you're using waist circumference, it depends on your ethnicity as to what, you know, is considered to be dangerous. And so I've put those numbers here that can just be used as a reference if you choose to use that as a metric, okay? What are some of the health risks that are associated with carrying too much excess body fat? So this is not an exhaustive list, but it gives you an idea of some of the things that can occur if you are dealing with obesity or overweight. And what happens is a lot of times you'll go to the doctor and the doctor is treating some of these secondary conditions, but maybe not helping you treat the primary thing, which is the excess weight. But sleep apnea, high blood pressure, cardiovascular disease, high cholesterol, some GI issues like reflux, urinary issues like incontinence. You know, the knees carry a lot of this extra weight, so increases your risk for knee arthritis, and you might need knee replacements. Some reproductive issues, of course, diabetes, fatty liver, asthma, and some mood disorders are associated with carrying excess weight. Okay, so when patients come to me and they want to work on losing weight, the first thing we do is talk about what is realistic in terms of expectations for weight loss. Because, you know, if you're significantly overweight, of course, you want to lose a lot of that excess weight. But unfortunately, that's really, really challenging to do. And I really want people to set realistic expectations so they can meet those goals and feel successful. So, you know, this has been studied many, many times. Lifestyle improvement, which we're going to talk about how to do that in terms of diet and exercise and mindset work and such, we can expect to achieve 5 to 10% of total body weight loss. If you add obesity medications, which there are some FDA-approved obesity medications your doctor could prescribe for you if you meet criteria and you're a good candidate for them, you can increase that to 10 to 12% of total body weight loss. Bariatric surgery is actually the most effective tool for achieving significant weight loss. We can achieve 30% of total body weight loss It's not the thing for everybody. But I put it out there because I think a lot of people don't consider it, and it is, a fairly good option for people that are significantly overweight, and we should consider it for those patients. Dr. Castillo, I think we forgot to do our poll.
Yep, I got it right here. I didn't want to interrupt. So
Oh, I'm so sorry.
Oh, you're perfectly fine. Yeah, let's go ahead and relaunch. We want to get a better idea of, who's here tonight. So I'm launching a poll question. Dr. Marathe, can you see that?
Let me see if I can see the poll. I'm not able to.
Okay, well, I'm going to read it. I see our audience is participating. So the question says that I'm attending tonight's town hall mostly because I am looking to learn more about weight management for myself. I am looking to learn more about weight management to support a loved one. I am generally interested in learning about weight management or another reason. So we'll give folks a few more seconds to answer. Looks like we have. All right, there's a few more. We have about 10 more people that haven't answered. So just a few more seconds and there we go. All right. I'm going to go ahead and close the poll. And it looks like most of our audience tonight is interested in learning about weight management for their own selves. So,
okay, wonderful. Great. Wonderful. And Dr. Castillo, please interrupt me and pop up the poll when you feel it's best. So I apologize, that was my fault. So I was talking about realistic weight loss goals. Aiming for 5 to 10% of your total body weight loss. So sometimes my patients will say to me, "Well, I'm only going to lose 10%." Let's say you have someone who's 200 pounds, right? And so 10% is 20 pounds. And I think that's a good goal, and they're going to say, well, losing 20 pounds isn't going to help me at all, and because they feel like maybe it's not going to help them get into the stress size that they want or something like that, right? But it's going to do so much for them, really. It's going to do lower their blood pressure, improve their heart health, lower cholesterol, decrease the risk for diabetes, or if they're already diabetic, improve their diabetes control. It's going to give them more energy, decrease risk for many types of cancer, and it's going to improve their sleep quality, especially if they have sleep apnea. So we achieve a lot of benefit with a fairly modest amount of weight loss. It's worth the effort.
Many times, Dr. Marathe, I tell my patients, you're working on this not only for your future self, and for how you look and feel right now, but for yourself in 5 years and 10 years. This is really going to impact your quality of life, in as little as 5 years. And so we got to kind of look ahead.
Yes, absolutely. Absolutely. So, how do we even get started with trying to figure out how we're going to lose this weight? Okay. So what I say to people is start where you are. That's the only place we can ever start, right? Anything. We just have to start wherever we are. And, a lot of people, unfortunately, stigma around weight still exists. And it seems to be the last thing that it seems to be in culture, society, okay to still have that stigma. And I work really hard to disavow that from my patients, because they carry their own stigma about their weight. And so they often come to me with judgment or shame for being the weight that they are. And, we can't even get started until we get rid of that, because that's going to hold them back from success, right? So, and we're going to talk about how obesity is a disease. It's a metabolic disorder, in fact. And it's not really a lifestyle choice, like a lot of people think that it is. And I think once they start understanding that, it puts them in a place, a mindset in which they can make these efforts, because otherwise they beat themselves up all along the way, and that never leads to a lot of success. Okay, so we start without judgment or shame, right where we are, and we start with curiosity. How did we get here? What's our weight history? Were you big from when you were a little kid or a teen, and you've always been a larger person than your peers, let's say? Did you not start gaining weight until after you had kids or after menopause? or after your work got so crazy and you were traveling a lot, or, what is your weight history? Have you gained and lost and gained and lost, or just been steadily increasing? That helps me a lot in terms of thinking about what could be the causes of the weight, issue, and how we can attack it best. And then, nobody gets to be significantly overweight unless they have eaten at times when they're not hungry. We all do that. But people that are carrying excess weight often have done that a little bit more. So what has driven you to eat at those times? Is it binge eating? I've picked up a lot of binge eating disorder in my practice. And if you ask the right questions, you can pick that out, and it's actually a mental health issue, and we can treat that. There's medication that's approved specifically for binge eating. So really important to figure that out. Are we doing emotional eating, trying to eat when we're stressed, eating at night, eating mindlessly in front of the TV? Like what's happening around our excess eating? What kind of food are we eating, and how much food are we eating? And also beverages, sugar sweetened beverages is a big problem for a lot of people. They maybe don't eat excessive amounts of food, but they're drinking, 2, 3, 4 sodas and sports drinks a day, tons of extra calories. What's the alcohol intake? Alcohol is empty calories. Not that you can't have any, but like if you're having a lot of alcohol, 1, it's excess calories, and 2, it impairs your ability to make good decisions after you've had the alcohol. And oftentimes people who drink will eat more after that. What level of activity are you at? Are you exercising regularly? Are you not exercising at all? It's okay. We need to know where we're starting, and then we can work from there. Sleep is so critical. So there's a direct correlation between poor sleep quality and struggles with weight. So we have to get that right. And then using that information, we can come up with the type of plan that's going to work best for you, because it's going to be different for every patient.
Dr. Marathe, I think it's a good time to ask our, talking about shame and everything that comes with this, I think it's a good time to ask our audience if they've ever asked their doctor to help them with their weight. Yes or no, right?
Right. So while people are answering that question, I did some research about that, and most people that are overweight or obese have actually not asked their doctor to help them lose weight. And it's because they think this is something that they hold judgment either on themselves about it, or they don't think their doctor can help them. And so, they're not bringing it to the table a lot of the times.
I've heard a lot of, this is my fault, I'm not doing something right. So like you said, self-judgment, and there's that holding back. And then fear of being judged too. I think there's, I've heard that as well.
Absolutely. And it's very possible they have been judged. Unfortunately, there is, stigma in the medical community. And, these people have encountered physicians who maybe subconsciously or consciously did judge them. And I feel terrible that they've had that experience, and that really affects their willingness to come forward and ask for help down the road.
And it looks like, we're close to the 50-50. We have 59% saying that they have asked their doctor for help with weight management, and about 41% have not. So,
okay.
I'm going to bring up a similar, kind of related, but almost the other side of things. If you're overweight, has your doctor brought this up to you?
This will be interesting. This will be interesting, because I do feel like, many physicians don't know how to help their patients lose weight. And, primary care doctors, and doctors in many fields, we were not given this training, right? In medical school or residency around nutrition and such. That's one of the reasons I actually went and I got my obesity certification, because I wanted to understand that. No one had ever taught me any of that before. And actually, I've been practicing for 25 years. A lot of this information around weight management, the new medications, none of that was available 10 years ago. This is all fairly new information. But I think doctors don't have a comfort level around this a lot of the time. So
I agree with you. It's the, what do I say if, right? It's
Mhm.
also
Mhm.
time constraint. There's so much to it.
Yes. Yeah.
But interestingly enough, about 76% of our audience said that their doctor has brought up, being overweight or is struggling with obesity. So,
Yeah. Okay.
um,
Okay. So that's interesting. And I don't think we have time for the second question to that is, did your doctor bring it up, but then did they give you actionable tips, like to actually, or did they kind of put it on you to say, you need to lose this weight. I'll see you in 6 months.
mhm.
And then kind of, you know what I'm saying?
It kind of
So
leaves you there with the
yes,
issue
yes. And
and
I
really
think,
no tools to tackle it.
yes,
But
I
we are
think that
lucky
might,
tonight to have you
oh,
help
you're
us a
so
little
kind.
bit with those. So,
Well, hopefully people will get something out of it. Excuse me. Okay. So, once we come up with kind of what got us here, in terms of the background and such, I'd like to really help patients understand their own brain because everyone's different. Everyone, as it relates to habit change and accountability and discipline, everyone's a little different. And it's not that one way of being is better than another. But if you don't understand how your brain works, you might not be putting systems in place that will work for you. And so I have my patients do this quiz. So this is the Four Tendencies quiz. So you can just Google Four Tendencies quiz and take this online. It's a free quiz. It was created by this woman named Gretchen Rubin, who she's a lawyer by training, but she's really interested in the psychology of behavior change. And so I have all my weight loss patients do this quiz, and they're really interested with the results. I can sort of predict what people are going to be after I get to know them a little bit. But what it is basically it determines how you respond to outer expectations versus inner expectations. So your inner expectations are your goals. So like, I want to, walk a mile every morning before work. I want to eat healthier. I want to do this, this, and this. Okay. Those are some of your inner expectations. Outer expectations are maybe, I show up to work on time. I don't run red lights. I don't, that kind of thing. Right. And so some people really, the ones that like external accountability, they often will not respond to their own goals. They're like, I just don't understand. I want to do this, but I just can't get myself to do it. But if someone else tells me to do it, I will do it. So many of my patients, just by the nature of what I do, that I am a doctor who helps people lose weight, they've already struggled. They haven't had success. They come to me. They tend to be obligers. They are needing this external accountability. And that's why they've come to me. They just didn't know that. So this is what their experience has been. They will do things if someone makes them do it, basically. Even if it's something they wanted to do, someone else has to help them with that. So if they want to go running, they have to, maybe join a running club, or, their neighbor shows up at their door at 9 o'clock every Saturday morning. They'll go running then, but they're not going to go and do it by themselves. But if you know what you are in terms of this, you're going to be able to put in a system that will work for you around your changes that you're going to need to make. Okay, so the next question I get after we figure out how your mind works, and we want to figure out what we're going to do. Okay, so I just put up here some dietary patterns. So you probably have heard of so many of these: Mediterranean diet, ketogenic diet, paleo, maybe whole foods, plant-based, which is like a vegan diet, intermittent fasting, or time restricted eating. So many different dietary patterns. I don't like to use the word diet. It has a stigma around restriction, deprivation. So we use the word dietary patterns or nutrition plan or whatever. So, there's lots of choices here. I'm not a nutritionist. I don't pretend to be. I don't have a favorite. So my patients will ask me, what nutrition plan should I choose? I don't care. You choose the one that you can do, that works for you, and that you will do forever. Because this is not a fad diet kind of thing. We are trying to lose weight for the last time. That is our goal. So I really, my goal around working on this issue with patients is that I want them to enjoy food more than they ever enjoyed it before. This is not about deprivation. This is about changing your relationship with food. And so it doesn't matter to me. There's never been a study that has shown superiority of one plant over another in terms of success. So do what works for you. I do think in general, moving towards slightly more plant-based, less processed food, less carbs. We probably eat way too much carbs, especially simple carbohydrates like, white bread and rice and white pasta, moving a little bit away from that. And then, so just my, broad general tips around nutrition is like a little bit of time restricted eating, but beyond that, do what works for you.
And Dr. Marathe, just as background, it seems like about 89% of our audience has tried at least once to lose weight by following a diet, if we want to call it.
Yeah. Yes.
So most of our staff has.
Yeah. And I think that's very common. And that's why like fad diets, they don't work because they wouldn't be here if it had worked, right? Like, so we don't want to call it a diet. We want to this is what we eat and this is how we eat. And this is what we do every day, all the time. Okay. So lots of stuff on the slide. Don't, get lost in that, but I just wanted to highlight a few things. Do we have another poll, Dr. Castillo, that we wanted to do at this point? I don't remember.
Yeah, I think we're good for
now. Okay. All right. So like I said before, I wanted to kind of highlight the relationship with food, right? So when we were babies, or anyone who has kids, you're feeding your baby or your toddler when they start eating solid food, right? When they're done, when they're full and there's still food left in the jar, are they going to continue to eat that? Or are they going to turn away from it, right? They're tuned into their satiety. When they're full, they're full. They really will not eat more than that. So we're born knowing that, but then we lose that. We start eating whatever is on our plate, even if it's more than what we really want, because we think visually we're supposed to eat all of that, or our parents told us you have to finish your plate, and so we got out of touch with our internal satiety. We need to get back in touch with that. We want to start eating more mindfully, enjoy the experience, make conscious choices about what we're putting into our body. A lot of times we only think about the palatability of food, how good does it taste, but we really also, and it should taste good. So I'm never wanting my patients to eat food that doesn't taste good. I don't want to eat food that doesn't taste good, right? So not only does it have to taste good, but it has to nourish us. That's the purpose of food, right? It's to nourish our body. And eating used to be, and it should still be, an activity in and of itself, spent with our family at the table, sitting down, right? A time where we connect, we talk about the day. Let's get back to that. Like some of that stuff that our grandparents did is probably what we need to go back to when it relates to food and nutrition. Okay. So, these are just some tips around mindful eating. Okay. And here we've already made a plan. And I think it's really important to think about why you want to lose weight in the first place. If you're doing it for anything other than, good health, then you might not get where you want. But if you're doing it to get yourself healthier, then guess what? You get to achieve the benefits before you even lose the weight, because the behavior change in and of itself is success, right? So it's the strategy is the success, and the weight loss at the end is sort of icing on the cake, which is a weird analogy. I just recognized when I said that, but you know what I'm saying? All the steps along the way are success in and of themselves, okay? And I put this on here because this is when we're trying something new that's hard, we don't want to do it. Our brains don't want to do the hard things, And so at some point we get to a tipping point where we think about we want to do it. We may go to the doctor and say, how do I do this? We're talking about some of the strategies about how to do it. And then you might want to try to do it. But then what they don't show is that people fall back down, right? So one of the things I always tell my patients right from the get-go is it's not a straight steady slope. You're going to slip and fall here and there. So you anticipate that. Because if you don't anticipate that, when you come off your plan, when you have a bad day, you can go off the rails completely. You can stop completely because you feel like a failure, right? Or you go on a binge or something like that. So if you anticipate that this is going to happen and bumps along the road, and you allow yourself a little grace around it, then you get to keep going, up on your plan and sticking with it.
And Dr. Marathe, can I ask, a lot of your patients, like you said, have tried over and over so many different things, and there's the frustration from it. And so how do you approach okay, let's start this for the last time, hopefully. Mm-hmm. Kind of how do you tackle that with them?
If they're not ready, is that what you're saying?
They're coming to you, they really want to lose the weight. They want to be healthy, they want to feel better. They've just started and then a diet or whatnot, and then they've gone back because it's too restrictive, it's too hard to follow. How do you help them change the mindset? Yeah.
So, I think, I do spend a lot of time in the beginning around self-compassion and nourishing of their own sort of soul and self, which has been beaten up by, the stops and starts and struggles and things like that, and just the stigma of living in a larger body, right? So I think part of it is that. So we won't do hard things for ourselves unless we value ourselves. And so I spend more time probably on the self-compassion and self-esteem part, especially for my young women that are struggling. I feel like they, take that internally, maybe more than some of my other patients do. So I start there. And then what we do is we look for, the analogy is low-hanging fruit. What's the easy things that we can do, right? So, as it relates to behavior change, if there's, small things that are easy to get rid of that you shouldn't be doing, let's try to get rid of one or two of those. Just do baby steps. What I want to do is start with success. So I want to put just one or two things in place that they can do, that they know they can do. And then we check in after a week or two, and they'll have been successful. And that our brains want success. It's a dopamine hit for us. And part of what we do is we do a lot of tracking. And I'm going to go over this in a minute here, because if we're not measuring our success, we won't be able to celebrate our wins, and then we'll slip back in. So that's kind of how we move them. We just lean into it, and we start with success.
Okay. And just, I know you asked me to help keep you on track. It's about 7:35, so I just want to.
Okay, very good. Do we have another poll question or no?
So whenever we're ready to tackle the pharmacotherapy, that will be the next one.
Okay, perfect. Okay, so a few more things just about mindful eating, tuning into food. This I like to use this with patients. It's the hunger scale. Okay, so tuning back into our hunger. We've all been here where we're like ravenous, and we don't care what is put in front of us. We are going to eat that. We do not want to start eating when we are ravenous. Okay, because we will eat too fast, we will eat too much, and we won't enjoy our food. And I think we've all been on the other side where we've sort of gotten ourselves into a food coma. We've just eaten too much, and that doesn't feel good either. So I like to just keep people sort of here and here. We want to start eating when we're hungry, but not ravenous. Stop eating when you're about 80% full, because your brain takes a little longer than your stomach to kind of tune into the fact that you're full. So you'll feel like you're only 80% full, and then you walk away, and then you'll feel full. So I think every time you eat, try to tune into that, and you will start retraining your brain to listen to those cues again. Okay. All right. So some just healthy eating tips in general. I think this one is really important, and something that a lot of people don't think to do is to plan ahead, to schedule time on your calendar to plan your meals for the week and actually prep them. If you don't put that time in your calendar to do that, then you are going to grab whatever is convenient and available, right? So if you take the time to plan all your meals, get creative, this is a great opportunity to look at cookbooks or new recipes, try new things, maybe go to farmer's market, and then prep. And I put meal and snack planning because, if you're in the habit of snacking in the evening, it's going to take some time to break that habit, but you're still going to want to do it. But if you have planned and prepped those snacks and portioned them out in a appropriate portion, you're not going to be eating out of a huge bag of chips while you're watching TV. It also teaches your brain. So we have a higher brain that is our thinking brain, that is really interested in our weight loss goals. We also have a lower brain, sort of our limbic, our hedonic brain, that's in charge when we're super tired and, exhausted or emotional. That part of our brain has no interest in our weight loss goals. It just doesn't. It wants comfort right then. And so we want to use our higher brain when we can to do all the prepping and planning and everything like that. And then the systems in place. So when we're tired and exhausted and our lower brain's opening the fridge and looking for something, it's going to find something healthy. Okay. When you go shopping, shop the perimeter of the grocery store, find the fresh produce, fresh meats, that kind of thing. Avoid the processed foods that are in boxes and packages in the center of the grocery store. Don't drink your calories. Balance your plate. So we used to, when you were younger, you might remember where there was the meat took like 2/3 of the plate, and then there was but now we've changed it around. So your plate should be at least half full of high fiber fruits and vegetables. And then the other half should have, a protein of some sort and a little carb, hopefully a complex carb, not a simple carbohydrate on that. And that's how we're wanting to eat nowadays. And it's much healthier for us. The size of the plate actually matters. So our brains will tune into how full is that plate. And, so use a smaller plate. It'll feel like you got a full meal. Eat slowly and mindfully. Stop eating when you're 80% full. Physical activity. I spend some time talking about this with patients. It's not a big part of weight loss. Probably 80% of weight loss relates to the food that we're putting in our bodies, and maybe 20% has to do with physical activity. But physical activity is really important because once you lose the way to keep it off is to exercise a lot. So if you have not been exercising, that's going to be hard for you to do. The other thing about physical activity, I would say, is one of the drivers of basal metabolic rate is muscle mass. This is why men have an easier time in general losing weight than women, because they have more muscle mass. So their metabolic rate is higher. So we can work on building muscle mass to increase our metabolic rate. So in the interest of time, I won't go through this, but I actually give my patients a prescription, and I get them to really drill down, be very specific on what they're going to do. Nowadays, we can use, workout apps and other ways of getting little snacks of exercise, 10 minutes here, 10 minutes there. You can work out at home. I actually pull out my phone and show the apps to my patients that I use, and I'm able to kind of motivate them a little bit. You don't have to have a lot of equipment, and work it into your day. So this is really important, tracking. This is what's going to keep you staying successful. What's measured is managed. If you don't measure it, you're probably not going to manage it. Weigh yourself weekly. A lot of my patients in the beginning, they don't want to hop on the scale. They're afraid to look at the number. It's just a number. It's a data point, and we have to get rid of all the negative energy around that number. Otherwise, we're not going to be able to deal with it. Some patients that really can't get past that, and so we just don't put it, we deal with it otherwise. But I think for most patients, if you can get yourself to weigh yourself weekly, one thing is when you start losing weight, you'll look back and you're like, oh, I did this, this, and this, and that's how I got here. Well, then I'm going to be more likely to continue to do that. So keep a food journal. Studies have clearly shown that people who food journal are much more successful at losing weight. And then also track your activity in some way. You can use a step counter, any other just minutes of activity, but keep track of everything. Okay. So those are just some tips around lifestyle that I offer to my patients that I think can be helpful. This is the problem. They can do all those things and they can still struggle. Okay. And this is because obesity is a chronic disease. It is not just, it's not a lifestyle choice. It might have started with some lifestyle things. There's also genetics. There's a lot of variables. Well, once you have gotten to a body weight that is in the obese category, it just changes your metabolism. Okay, so you take two people who are the same weight and the same height. Let's say we have someone who is 5'6", 150 pounds. Okay, one person has been at that weight all their adult life. The other person was at a higher weight and has lost weight, and that's where they are. They're the same height and weight right now. They are not metabolically the same, unfortunately. The person that has lost weight, their body, their metabolic set point is at the higher weight that they were before. Their body wants to get them back there, and it will defend that. So this is why people, quote unquote, relapse. They struggle. Their bodies are pushing them back to this higher weight. So it takes so much vigilance and effort to maintain weight loss if you are able to lose weight. So if your doctor tells you, just eat less calories and move more, I don't think that doctor has tried to lose weight before, perhaps, because you can tell them that you've tried that and it hasn't really worked that well. This is why, okay? So this is, suppose you're here, right? You're doing the things that we've talked about. You're eating less, you're moving more, and you're losing a little bit of weight. But then once you've lost some weight, your metabolism slows. So your utilization of calories by your body, now you need actually less calories just to maintain that same body weight. So where you might have needed 2,000 calories a day before, now you only need 1,500. Well, suppose you ate 1,500 to lose weight. Now you have to eat less. You have to eat 1,300. It's very difficult, right? And then, but on top of that, hunger hormones are going up. You're actually hungrier now. Your fullness, satiety hormones have gone down. So everything is working against you in terms of keeping that weight off. So this is what it feels like, right? So you're doing what you need to do in terms of healthy eating, physical activity, but these waves are coming at you and fighting against you. Increased hunger, decreased satiety, and there should be a third wave, which is decreased metabolic rate. So this is metabolic adaptation. This is a real thing. This is what happens. And this is why you might need your doctor's help to successfully lose weight. And so we're going to talk about some medications, pharmacotherapy, FDA approved medications that can help you lose weight. And the criteria, not everybody meets criteria, but if your BMI is over 27, which is an overweight category, and you have at least one, disease that is associated or due to being overweight, such as diabetes, high blood pressure, that would put you in criteria, or anybody who has a BMI over 30 would meet criteria for weight loss medications. This might be a time to do the poll, you think? Dr.
Yep, we have it up. Would
Okay.
you consider taking medication to help you lose weight? We've just had about 17 of our 39 folks. If you'd like to go ahead, I'll give you the results in a minute here.
Okay. So when should you even consider weight loss medication? So you might want to consider asking your doctor about medication. If you are, doing the lifestyle stuff, you're doing the best that you can, and it's just not coming off, or it's not coming off, to the degree that you had hoped, or if you're struggling with actually doing the lifestyle stuff. I feel like we punish our patients sometimes for not being successful with lifestyle measures. We don't punish them. I suppose they're not sticking to their low salt diet. The doctor's still going to give them the blood pressure medication. Not like they're going to send them out and say, once you stick to your low salt diet, then come talk to me. You know what I mean? So that might be a time, but we have to talk to patients about weight loss medication. They're really underutilized. Most primary care doctors don't feel comfortable prescribing a lot of these medications. They're fairly new. And patients don't even know about them. Only 2% of patients who meet criteria get a prescription for weight loss medication from their doctor. And then even if they get the prescription, The next hurdle is getting it covered by your insurance. There's just very spotty insurance coverage for these medications, unfortunately. So.
And about 68% of our audience said they would be willing to consider taking medication to help with weight loss.
Okay, okay. So we don't have a lot of time to go through them in great detail, but I just wanted to put this up there to show people that, there are a number of medications now that are FDA approved for treatment of obesity. So the oldest medication is phentermine. It's been around since the 1960s. You might recognize it because it was part of something called fen-phen, which was taken off the market. And fen-phen was phentermine, PHEN, with fenfluramine, which is the FEN, as the FEN one that was taken off the market because it had an association with some heart valve issues. But phentermine is still on the market, and it is, in the right person, a safe medication. It's only approved for short-term use, which is really interesting because when it was combined with this topiramate and branded as Qsymia, this company went and sought long-term FDA approval, and they got that. So somehow phentermine can be used long-term as long as it's, prescribed in this way. But if you prescribe just plain phentermine, it's only approved for short-term use. It is a controlled substance. It's a stimulant that works by suppressing appetite. Some of these others, there's allies available over the counter. This is the prescription version of it. I don't use this medication very much. It blocks fat absorption, orlistat. People, if you're blocking fat absorption, it has to come out in your stool. People don't like that. They can have accidents. It's not a great thing. There's some combination meds. I talked about this one, Qsymia. This is an effective medication. It's probably one of the more effective of the oral medications. These first four you can take as pill form. These last you're going to take as injection, okay? Naltrexone and bupropion. This is a combination of, this is Wellbutrin when it's by itself is an antidepressant, and naltrexone is, it's a medication that is similar to Narcan or naloxone. It's an anti-opioid, has to do with the receptors in our brain. It decreases cravings. So both of these basically they work in our brain and they decrease cravings and hunger. These others down here work metabolically. They're different. They started as diabetes medications, and these two have been approved as obesity medications also. This new kid on the block, tirzepatide, it's similar to these, but actually more effective, but it does not have an FDA approval for obesity yet. I'm pretty sure that will be coming because it's more effective than anything else on here. These are all injection medications. This is a once a day injection. People aren't using this as much because it's made by the same company makes this medication, which is once a week injection. So, but they're very effective. They work on gut hormones to decrease hunger. They regulate all the hormones in a way that is exactly what we need when we have that metabolic adaptation. So we have some things that are available to us to consider for our patients. Not each drug is for everybody. They have potential side effects, and so you and your doctor would need to go through them and see if one of these is a good choice for you. Let's see. Okay. All right. Bariatric surgery. This is something to consider if your body mass index is over 40. So this is for a patient, we call that stage 3 obesity. So people that are really heavy. Now, the prevalence, of stage 3 obesity has gone up by 70% just in the past 10 years. So the really large patients that are dealing with a BMI over 40, they are going to have a lot of trouble losing a lot of weight. And we really should consider bariatric surgery for them, and they should consider for themselves. So many people are so resistant to the idea of bariatric surgery. They might have heard about somebody who had it and had a problem. Bariatric surgery has evolved so much over the past probably 15 years. The surgeons now are so much more experienced than they were before. Most surgeons that are doing bariatric surgery, that's all they do. They're not doing other types of surgery as well. They're getting a lot of cases and very experienced. So I think it's something that we should put on the table for these patients. I think we have a whole question.
I'd like to emphasize that as well. We put the poll out and about 75% of our audience said that if they were a candidate to, we asked them if they would consider weight loss surgery if they were a candidate, and 75% said they wouldn't. And I think that's representative of what we see in the office as well.
Okay. Okay. All right. So I wanted to just quickly go through the two most common types of bariatric surgery that are being performed right now. They're both done laparoscopically these days, most of the time. And the first one is gastric sleeve. And this is, let me just, my slide. Okay, here. So this is the stomach. And this is the part of the stomach that's been cut out. Okay, so normally our stomach looks like this. And so then after the procedure, it's basically like a long column instead of a sac. So they cut out the majority of the stomach. This is irreversible, okay? It is less invasive perhaps than the gastric bypass. It's a pretty short hospital stay. I think it's one night, if that even. But the problem is that a lot of vitamins and iron are absorbed in the stomach. So now you have less stomach. So you're gonna have to take some vitamins and you have to take iron for the rest of your life, okay? It can increase the risk of reflux. You can see how, once you change the anatomy of the stomach, you might be at risk for that. And then the next, there are other types of procedures. I'm only going to talk about these two because these are the two that are most commonly done. This is gastric bypass. This was done long before there was just gastric sleeve. So there's a lot of experience with this. This is also done laparoscopically these days. It's a fairly extensive procedure in terms of changing the anatomy. We won't go into all of that. It can achieve more weight loss than just the gastric sleeve, okay? So if you need to lose a lot of weight, this might be the procedure that is recommended for you. It says difficult to reverse. I think it's extremely difficult to reverse. So I would almost think of it as being irreversible, like the gastric sleeve. Since is altered in a lot of different ways. There's a lot of malabsorption issues that are to be anticipated, not just that could happen, that will happen if you do not take your vitamins and iron and everything like that indefinitely for the rest of your life. So you're committing to that. And there's some surgery related complications that can happen. This is a fairly significant, procedure, but it's also very, very effective. Okay.
All right, Dr. Marathe, we have about 5 minutes left.
Okay.
I feel like it's a good stopping point and address just a few questions that we have.
Yes.
If anybody has some last minute questions, please feel free to type them up. We have somebody from the audience saying that they have a friend that has been very successful with the Noom method or app. What do you think of that?
I like Noom a lot. I really do. I think, so you can probably tell from some of the things I said earlier that I do think that mindset work around why we eat Noom helps us with that. So I like Noom a lot. So it's, some of the apps are just tracking your food, but there's a cognitive piece to Noom, which is unique to that. And I think it's really good. I
agree. I've used it. It's not for everyone, but I found that, like you said, there's a big cognitive piece and that can be very helpful. That related to that, that's the only question we have. Somebody asked if these slides will be available to them, and we're recording this session, and so in about probably early next week, you'll be able to have access to this on the Northern Virginia Family Practice website under media. So that will be available. And then Dr. Marathe, if you have any additional resources you'd like to share with our audience, if you'd like to share our presentation, we can also include that in the section where we post this, okay?
Absolutely.
All right.
Absolutely.
I always like to try to finish if we can, with a few take-home points. If you wanted 3 things for our audience to take with them, what would you share with them? Okay, so I would share that, we need to destigmatize, being overweight or struggling with obesity, that this is, it's a real chronic disease. And
from that mindset as a society and culture, we can tackle it. That's number one. Number two is it's hard to lose weight, but you can do it, but you probably need a lot of support, and come to your doctor for support, and consider getting help through medications or surgery if needed. I just think those are underutilized, and we should put those on the table more than we are.
Great. I love those 3 points. We do have about 3 more minutes. So we did have a question about your thoughts on programs like Isogenics or Optavia.
I don't know exactly what those are, but they might be programs that are where there's a meal replacement portion. I think that's kind of what they are. And, so my struggle around those kinds of programs is, you're not going to do them forever, right? So meal replacements do have a role actually in weight loss for some patients who are really struggling around the mindset of why they eat, when they eat, all of that. When you have a meal replacement, it just takes the decision off the table. And then they can do their mindset work and their healing and all of that, and not have to make it. So, when you have, say, a food addiction, it's very challenging because we have to eat. If you're addicted to drugs, well, you don't have to take drugs. So you already get to take that off the table. But unfortunately, we don't get to take food completely off the table. We have to eat. So that's where meal replacements come in for patients that are really struggling with food addiction and they need to do the mindset work. I just worry people lose weight on some of these kinds of programs and then they stop. And if they haven't figured out a way to eat healthfully for all their real food meals, they're going to gain the weight back.
Okay. Squeezing out every last minute, we have a question. For a person who has lost a lot of weight, do you recommend skin surgery to avoid infections?
I don't know about avoiding infections specifically. I have had a lot of patients, especially those that have had bariatric surgery, that do really struggle with that. And I think it's very reasonable to consider surgery. Especially if you have enough skin folds that you're getting infections, then yes, you should consider that. I think absolutely. And you'll feel better about yourself. You did the hard work to get there. So you put that last piece in place. Sure.
I agree 100%. I took the quiz. I am a questioner. So what does that mean? That might be a little more
boy, I have to remember. So I think a questioner is someone who does not like external rules and only will abide by rules that they have set for themselves, right? And so a questioner is a great place to be because once you decide, like say I'm your doctor and I tell you, you need to lose 20 pounds and this is not how I practice, but let's say I tell you have to lose 20 pounds and this is how you need to do it, okay? And you're like, no, that's not gonna work for me. This is how I wanna do it. Well, guess what? You're gonna do it then because you decided for yourself. So a questioner will actually follow through, but they have to decide, they have to incorporate it as their own values and decisions. So I think that's great.
All right. Well, once again, the presentation will be available on our website. That's nvafamilypractice.com. Dr. Marathe, thank you so much. I feel like we could talk about this for another 2 hours. There's so much to cover here, but yes. I feel like this was a great, kind of a great dive into it. Thank you again. It's been a pleasure. Have a good evening, everyone.
Okay, bye. Thank you.
All right. Thank you. Bye-bye.